السلام عليكم ورحمة الله. Good afternoon, ladies and gentlemen. وجمعة مباركة إن شاء الله. I'm really excited to be here today and to share and more importantly to learn from experts in this field. And also I would like to thank the organizers and the kind invitation from Foundation Medicine to give this talk. So the topic today is the impact of precision medicine on the management of cancer of unknown primary sites. This is my disclosure statement. I have no financial disclosure. And cancer of unknown primary sites, or as well known as occult primary tumors, is basically histologically proven metastatic malignant tumors whose primary is unknown at the time of the pre-treatment evaluation. They represent 2 to 8 to 5% of all malignancies, and they are really difficult to pinpoint. It's so difficult that even in the post-mortem, 20 to 50% is still undiagnosed, or we cannot find the primary. So given the time, given the resources, the dynamic of the tumor has stopped, and we still cannot find the primary tumor site. And if we don't know the primary sites, we usually go to ablative chemotherapy. And how did we do well in the last 30 or 40 years? Well, according to the Australian National Health Institute, we did not do very well. This is the 5-year survival rate. And you can see there's a slight increase in the survival in the last decade or so, but still we can do way better. So there is clearly unmet needs for the treatment, diagnosis, and managing this subset of patients. I'm a big fan of detective shows where they bring unknown victims and follow up the forensics and trying to figure out how the whole thing will pan out. And usually they start with a name that's repeatedly I hear, Jane Doe. So I did not know why they keep repeating the same name from different shows. And it turned out that this is a generic name. They give it for every unidentified victim, usually women. If they are men, they call them John or Doe. And this name will stick with the victim until they find out or identify this person. So, for example, there is a victim in Long Beach. They gave her the name Jane Doe based on the analysis. They know it's from the contour of the body and the bones in 1974. They construct the facial. This is a forensic facial figure for this victim. And they're trying to identify this victim, and the end goal is to bring the criminal to justice. So we cannot bring the criminal until we understand or know who is the patient, who is the victim first. And when I'm looking at the CUBs, it seems like the CUBs to the managing team is really what the Jane Doe is to the detectives. We have to know the primary site first in order to give treatment. And currently there's two types of treatments. One is we give site-specific treatment if we know the primary site. Otherwise, we give the palliative treatment. And the core of this talk today is how the precision medicine toolbox help us in this cycle. So the core of this talk is that we have we can intervene with two places. On one side, we can use precision medicine tools to improve our ability to identify the primary tumors. And if we do that, we continue business as usual, the site-specific treatment, for example. But the more exciting thing is actually the biomarker-guided treatment. This enables us actually to bypass the identification process. So it's really a faster way of going. We don't need to identify the victim or the tumor. We just go for the treatment. So I will explain what are the current tools that we have today, how good they are, and what's the current status, and where's the future direction of these toolbox. So how do we do search for the primaries? We throw everything we have, mainly 3 modalities, the imaging, the endoscopy, and of course the pathology. And in pathology, we have the immunohistochemistry mostly and the molecular assays. Under the light microscope, there are 5 groups of cancer of unknown primary sites. 80% of them are adenocarcinomas, which either well differentiated or poorly differentiated. 5% are squamous cell carcinoma, 5 poorly undifferentiated malignant neoplasm, and only 1% of neuroendocrine tumors. But this is clearly is not enough. This classification is not enough. We need to go deeper. And there are a few toolbox or tools that we can implement here. And to understand these tools, I will use the central dogma of molecular biology to give a logical workflow to understand when to use these tools. So basically, the central dogma says every nucleated cell has a DNA that codes for thousands of RNAs. Many of those are coding for proteins, and those proteins does many function in the tissues and the cells. So currently, when we interrogate the proteins, this is basically immunohistochemistry. So we're trying to figure out which protein are expressed in which cells. And the current practice is first, we will throw a survey of immunohistochemistry, trying to figure out what's the big vector there. And once we pinpoint one of these, we go with a details work with different panels until we reach a conclusion, either it's a specific tumor or a site. Despite this is a long-standing practice and there is a lot of progress, many reports says we can detect with strong evidence 33%. We can detect the primary sites. So clearly there is a lot to be done. So the question is now, can we do better? Do we have other tools to do? So let's revisit the central dogma again and take one step back, which is interrogating the gene expression at the RNA level. So one of the most important tools that we use today are the microarrays. This is small glasses with thousands of dots or circles. If we zoom in one of those dots, there is a standing probes, either DNA or RNA, that's specifically designed to capture a specific gene, RNA. If they hybridize, there's a fluorescence intensity. And we can see different expression from different tissues. And basically, these different patterns of signature are the fingerprints for these tissues. So we could predict which tissue based on the gene expression. Because there are thousands of gene expression, we cannot do it manually. So we use computer, actually. We feed it the intensities, the fluorescence intensities from the microarray. And you see this is the tree, and there is tens or hundreds of different tissues and tumors. And basically, this is a binary decision tree classifier. It will go and compare each patterns with the tissue and assign it with a score, the similarity, until it reaches the highest probable tissue. Then it will assign it a score. Currently, there are probably 5 or 6 different commercial gene expression tests. And they range from 10 genes to 1,500 different genes. And the accuracy is really good. They claim to achieve up to 92 in some of these assays. So 92% accuracy of whatever tissue you throw at it, they will know what's the primary site. Even the lowest one, which is the first one, it's used only 10 genes, but the accuracy is 76, which is way better than the immunohistochemistry alone. So this is impressive. So let's see one of these tests and how it's used. I chose this one because it's FDA approved, although there is some limitation, but it's the only one that's approved for this assay. It used microarray and it tests for 1,500 different genes. So this is the case. A 76-year-old woman complaining of chest pain and shortness of breath. The chest X-ray shows pulmonary nodule. CT scan revealed suspicious lesions in the liver and the lung, retroperitoneal adenopathies, and thickening of the cecum. The pancreas was clear. Breast exam and mammography was negative, as well as the endoscopy and colonoscopy. So they did find needle aspiration on a supraclavicular lymph nodes, and this is what they got. So you see there is a battery of immunohistochemistry, and if you noticed, CK7 is positive, the HER2 is 3+ positive, and the serum CA 19.9 is 14,000. So the pathologist impression at this stage is poorly differentiated carcinoma. Possible primaries include breast, lung, pancreas, stomach, salivary glands, and ovary. So this is a classical CUP case. So based on this, the follow-up was to repeat the breast exam and the mammogram. Both were negative. The PET scan showed diffuse activity in the lymph nodes, lung and left iliac region, and the left breast. The MRI and the ultrasounds of the breast were negative. So the impression of the oncologist is breast or gastric. They start the treatment on Gemzar or Xeloda and radiation to the left hip. But at the same time, they send it for this gene expression. And surprisingly, the first hit was bladder. So they went back and adjust the managements. The first thing they did is a cystoscopy, which was negative. Urine cytology was atypical, but not diagnostic. But the washings from the renal pelvis were performed and were positive for malignant cells. So this led them to the diagnosis of primary urethral carcinoma. And they adjust the treatment to Gemzar and carboplatin, and the patient improved. The CA 19.9 decreased to less than 200, and she survived 19 months until the return of this report. So this is really good and impressive, but it's still a case report, and there's many of these case reports all over the place with antidotes. So the question is, are there any larger studies? And one of the largest studies that used this assay recruited 107 patients, and in 65% of them, they changed the management after seeing the gene expression. Basically, the most changes happen in the chemotherapy and the radiation therapy. And they showed the survival since the biopsy, which reached 14 months, which is better than the average of the cups, but still it's not case control, so take it with a grain of salt. Later, another year after that, the largest study using this approach was from the Sarkan Research Institute, where they took almost 200 patients. The blue color are those patients with CUP and gene expression, and compared to the empirical treatments in 400 patients. And it shows that the average median survival per month is 12.5 for the blue group, compared to 9 months only for the CUPs. So there is some, I think, improvements, but it's not very great, but still encouraging. And based on these papers and publication, the current guidelines in the ESMO is basically, they say it may aid the diagnosis, but it's remain questionable. And similarly, NCCN guidelines, the latest one, is also saying the same exact message. They have this diagnostic benefits, but the clinical benefits has not been demonstrated. And I think this is basically they're waiting for that large randomized clinical trials to show the real effect. So this concludes the first part, which using the gene expression as part of the precision medicine into improving and our abilities to identify the primary types. But the real improvement is really comes with what precision medicine providing us, which is the faster lane. Basically, you can bypass identification of the primary sites and go directly to the guided treatment. And here, what we do basically in the central dogma is we are actually sequencing the DNA, but also the RNA, and we call this the comprehensive molecular profiling. In our lab, we are validating a panel of 70 genes. Basically, we extract DNA and RNA simultaneously from the tissue we receive, whether it's CUP or any solid tumors. It doesn't need to be a CUP. And at the DNA level, we are trying to figure out or detect 3 different lesion molecules. So Foundation 1 assay is for solid tumors. It's one of the largest panels available today, not for CUPs, for any solid tumor, with high accuracy and reproducibility that's already published. We are trying to see how good are we compared to this panel. So for example, the published data on this panel is it can detect with 99% sensitivity the point mutation, 98% for the indels, up to 40 base pairs, which is really long. For the copy number variants, it's a little bit lower, 95%, but you have to note also that it can detect 8 copies or more. So the equivocal cases, the 4, the 3, the 5, probably we need something else to validate. So it's not yet there for the copy number variants as we wish. But this is true not for foundation medicine, for any NGS panel. And also for the gene fusions, which detect 99% of them, the sensitivity, assuming that we have 30% of the tumor in the sample. So there was a recent study done using this panel, the foundation one, on 200 CUP cases. And it's staggeringly showing that 96% of them have alteration. On the average, there's 4 mutation per patients, and they divided into 2 groups: the adenocarcinoma CUP and the non-adenocarcinoma CUPs, and they have similar numbers. Most of those mutations are base substitution, which is almost half of it. So the good news here is that what you see here is the genes on the x-axis, and on the y-axis the percentage of patients who has a mutation in one of those genes. And there's a lot of targeted mutations that we can hit with the treatments, despite not knowing what is the primary site. And in the paper, it claims that 87% of CUP patients have targeted therapy using this approach. And this is an example of a report we get back from such NGS panels, where for one patient you see 4 or 5 different mutations, and for each one of these you have a suggestion of a treatment, approved treatment, whether it's as a first generation, second generation, or even the resistant mutations, which give the oncologist or the managing team the ability to choose based on the clinical severity of the patient. So this is really great because the precision medicine can help us whether we want to continue the current practice, just improve our chance of identifying the primary types, or if we want to bypass that and quickly go into directly giving the treatments through the sequencing panels of DNA and RNA. So before I close, I have to mention that there are new developments in precision medicine that's worth lectures by themselves, and one of them is the epigenetics. Basically, there's a lot of interesting research on the cancer showing how we can divide, cluster, and observe the patient's interaction with the treatments and the course of the tumor based on the methylation, for example. But this is still research, so maybe a few years from us. A more practical way and new advancement is the liquid biopsies from cell-free DNA, where we exactly can use the same panels into detecting from the bloodstream, especially on those who are difficult to get biopsy from. And this is also good for monitoring, and I think Prophet Dan will talk about it in a different lecture. So before I end, what's happened to the Jane Doe, the beginning of the lecture, 40 years ago? And actually in 2013, a guy called, I think, Gary Stamp was arrested in 2013, and he confessed to the murder. He did not know the victim. Still, we don't know who is she, but he brought to the justice. And I think this has captured the essence of precision medicine today with the sequencing. You don't need the identified primary tumors. It's still important, I think, but there is a promise that we can bypass that directly into the treatment, and we will wait to see the clinical randomized trials that will show us how effective is this approach. And I think there are a couple of trials ongoing. And with that, I would like to thank my colleagues at the Department of Pathology and Oncology Medicine at King Abdulaziz Medical City, the organizer of this great meeting, and also the Foundation Medicine for the invitation. Thank you very much.